To join me in a warm welcome for Dr. Vu. Thank you, Dr. Vu.
Well, thank you so much for being here, and thank you to the MGFA for this privilege and this honor. Here are my disclosures. I'm the site principal investigator for many of the trials out there. So if you hear me say we did this, that's where that's coming from. For today's presentation, I'm solely responsible for the content. So I'm going to talk to you about the history of MG and also touch on how MG developed in the patients and how it may impact the patients infected with it. I'll review the progress in treatment of MG. We'll talk about some future therapeutic options, and then we'll talk about what factors may impact your decision to choose which drug to use. So we'll start with the past. So this is not a new disease. This has been known since the 1600s. And the first patient reported was discussed by the Virginia chroniclers in 1644. So chief, it's an Indian chief who in his youth was victorious in several battles. And in his later years, had to be carried by his colleagues, and they had to open his eyes because he couldn't open them. And when he was arrested by John Smith, yeah, that John Smith from Pocahontas, you ever see the Disney version of it, he was able to rest and was able to walk afterwards. The first medical description of this is from Thomas Willis in 1672. He described this, what is it, prudent and honest woman? I guess that's the, compliment back then, who had weakness in her limbs and also in her speech. And when she spoke too much, she would go mute, and after resting, she would be able to speak again. So these two cases show you the cardinal features of MG, what we describe as fatigable weakness. So, you may be normal in strength, but as soon as you start to exercise or exertion, do some exertion, you start to get weak. And that is sometimes a problem because you go to the neurology office, you tell the doctor that you're weak, and when he examined you, you had normal strength. And then he's, sort of writing it off as your imagination. So MG is the autoimmune process. And before I get to the autoimmune part, let me talk about the immune part first. So the innate immune system is what we use to fight off bacteria, viruses, a whole bunch of other things. And so when those things get into your bloodstream, there's a signal that's sent to the T cells in the bone marrow, and then the bone marrow goes to the thymus. You can consider that's the training center, where the thymus get to recognize the antigen, the virus or whatever. And once it gets so-called sensitized, then it activates the B cells. The B cells then undergoing this process where they transform into plasma cells. And plasma cells are the cells that actually produce antibodies, and the antibodies would bind to the virus in this case and neutralizing it. So in MG, the same process happened, except that the T cells, instead of recognizing the cell as friend, it recognized the component of the neuromuscular junction as the enemy, the so-called loss of tolerance. And when that happened, they usually get eliminated, but sometimes they don't. And sorry. And so what happened is they activate the B cells, and the B cells again go to plasma cell, produce antibodies that attack different component of the acetylcholine of the neuromuscular junction. So you have the acetylcholine receptor, you have the muscle-specific kinase protein that organize the neuromuscular junction, and you also have LRP4 that cluster the receptor together to make it more efficient. For patients who have acetylcholine receptor antibodies, the process is a little bit different. And so there's three types of antibodies. It can bind to the receptor and block the signal from the nerve cells. It can bind to the receptor and the whole complex get internalized and removed from the surface of the synaptic membrane. And as a result, you have fewer receptors to interact with the nerves. And the most common types of binding antibodies that activate is something called a complement cascade. And that complement cascade end up destroying the neuromuscular junction. You can see down here, here's a normal membrane with all these receptors on it. Here's a patient with MG, where you see the postsynaptic membrane all destroy, and the black dots are the membrane affecting complex that are deposited on it. So as you can imagine, when you destroy the receptors, the signal cannot be sent from the muscle. I don't need to tell this audience what kind of burden you face, but there are multiple. And you know, I think of this to remind me of that myth, Greek mythology figures called Sisyphus, who was condemned by the gods to push the stone up the mountain, and then it slipped, and during the night, and the next day you get to do it all over again. And that's how I feel about patients with MG struggle, and there are many. You know, the weakness and the fatigue prevent you from being employed fully. It prevents you from participating in social events during your lifetime, and that can lead to social isolation. And you know, that's not to mention crisis and exacerbation that put you in the hospital and take you away from your natural environment. So because of these burdens, you can imagine that across the world, the incidence of people being underemployed or unemployed are fairly similar, roughly about 50%. In countries like the US, where your insurance is dependent on your employment, that create an additional problem because now you don't have the coverage needed for adequate treatment and prevention. So MG happened, I mean, you know, the least, like I said earlier, the earliest incident of it is in the 1600s. And from 1600 to the early 1900s, there basically was nothing out there. So as you can imagine, every time you go into an exacerbation or a crisis, you will die. I mean, basically uniformly fatal. But around the 1900s, early 1900s, when surgeons removed the thymus from patients with other issues, tumor, thymoma, whatever, they noticed that the MG, the patient with MG who have this problem actually improved. So that becomes sort of standard practice by the 1930s. So thymectomy was probably the first MG treatment out there. And then in 1934, Mary Walker was listening to this visiting neurologist who said that, you know, MG looks similar to botulinum toxin and toxicity. And if you treat it with pyrostigmine or something like that, the patient may get better. And so she did, and two patients. And that's why we refer to as the miracle at St. Alphege, the hospital. And so pyrostigmine started to get used in 1947. And it was grandfathered by the FDA in 1955 as the first FDA-approved treatment for MG. And you can see that with improvement in medical care in terms of respiratory support, and then in the 60s, steroids and immunosuppressant, the incidence of death decreased considerably. It's still there. I mean, you know, the risk of death is about 2 to 5% every year for a patient with MG. So before, we have had treatment for a long time. So some of the treatment in the last decades or so, a couple of decades or so, include hemectomy, that's been done for a long time. If you want to remove the immunoglobulin, the antibodies, you can use plasma exchange. And then there are several other medications that can be used to decrease the production of antibodies. So you can look at a treatment that's separate by two things. So you can have upstream treatment, that is turning off the antibodies, and then downstream treatment, mopping up the antibodies. So if you can use an analogy, think of a burst water pipe, right? So you can mop up the water using downstream treatment, and up until recently, we have nothing there except for plasma exchange. Or we can shut up the water main. The trouble with that is there's a lot of inconvenience involved. You shut up the water to the whole house, you're going to suffer elsewhere. So it's the same way. So if you start shutting down this pathway, you're going to put yourself at risk for infections and some of the medication have other side effects as well. The other trouble with the older treatment is that they have a long onset of action. So they take weeks to months to kick in, and the maximum efficacy is not reached until sometime almost 2 years later. And that's a problem because in this study by Grobe that published in 2007, once you develop symptoms of MG, about 37% reach the maximum severity at 6 months, 12% at 12 months, 66%, and by 2 years, most people have reached maximum severity. This study has been duplicated by others, but take a year or so. What's the problem with this is that if you clearly have trouble really fast, and if your medication takes a while to kick in, you're going to have a lot of suffering in the meantime. So when you survey patients, a lot of them say that delay of onset of effects is one of the major factors that lead to treatment dissatisfaction. Difficulty of inconvenient administration is listed at 1 out of 3 patients. Lack of efficacy was listed up to 41%. And then side effect of medications was listed by at least a third, maybe bigger, a larger population. So steroid is effective and achieved. But the problem with that is it has so many side effects as listed here. And it's probably my least favorite medication because I feel like every time I use steroids, I put the patient on top of the ugly tree and watch them hit every branch on the way down. Okay, so let me talk about the present. So 2017 was a pretty exciting year for me. This is the first MG trial that I was involved in, and that led to the approval of eculizumab in 2017. We actually started the study in 2014. And then efgartigimod came on market in 21, ravulizumab in 22, and then last year was pretty productive. We had efgartigimod, sub-Q, rozanolizumab, and zilucoplan all coming online as treatment options. So now the landscape changed a little bit. So downstream, previously we had only plasma exchange. Now we have complement inhibitors and also FcRn antagonists. And before I talk to you about all the trials that led to the approval of these medications, let me talk to you about the most common measure that we use in clinical practice as well in clinical trials. It's called the MG Activities of Daily Living, and it asks the patients 8 domains, question about 8 domains. How have you been doing in terms of talking, chewing, swallowing, breathing, and so on? And the score 0 is normal, 3 is unable. So the score goes from 0 to 24. 24 is the maximum score. And if you get that, you're in big trouble. You're on a vent, you have gastric tube, you have trouble moving. A decrease of 2 points considered clinically significant. So you take swallowing, for example, you can go from gastric tube feeding down to having choking occasionally. So that's a big improvement. Minimal symptom expression is when you have a score of 0, no symptoms, or one symptom very intermittently. So let's go to the complement inhibitors. And as I mentioned before, if you have anti-AChR antibodies, you have 3 different types of antibodies, the most common being binding, and that activate the complement cascade. So if you block that cascade, you prevent the formation of the MAC, which then prevent the damage to the postsynaptic membrane, and hopefully that preserves your function. Here are the 3 drugs available on the market, and you can see that they pretty much have the same pattern in clinical trials. So when we start the trial, we would put half the patient on placebo, and they all have a sort of a beneficial effect. That's pretty common in MG trials. But the patient who were treated with drug improved more, and you can see that this is really rapid improvement within a couple of weeks. And then when the placebo patient get put on drug at the end point here, they join the treated group, and both groups have improvement over time, and that effect is pretty durable. So the MG-ADL is a scale here, and the lower the score, the better you're off. And you can see that with ravulizumab, the same pattern, and zilucoplan also have the same pattern. The other thing we found that it takes a little while to maximize benefit. So in the REGAIN trial here, you can see that about 25% of the patients achieve MSE, minimal symptom expression. But then when you treat them longer, by week 130, you can see that about 70% of them actually got better, get MSE. Here are the 5 most common side effects across the group. Overall, they're not bad. People usually don't discontinue therapy because of these side effects. So I'll move up to the FcRn antagonist. And so FcRn stands for neonatal Fc receptor. So you have antibodies being produced all the time because you're facing different antigen during the course of your day. And so if there's no way of removing these antibodies from the bloodstream, pretty soon you're going to clog the bloodstream and causing strokes and whatever else. So the cells that line the blood vessels, the endothelial cells, will take these antibodies into the cells and destroy them. However, the cells also have a mechanism called the FcRn, where if the antibody binds to it, then it gets recycled back. This way, you don't destroy everything in the system. There's a way to recycle. Now, imagine if you give a drug that binds up all the FcRn, what happens is everything else gets destroyed. So you lower the antibodies level in the system. And with the efgartigimod trial, you see that to be the case. So here is the total IgG. The treatment was given weekly for 4 weeks, and you can see the IgG level go down. You can also see that antibody level also go down, and the patient improved in terms of ADL score. Efgartigimod then tried the subcutaneous version because that may be a little bit better to give, and you can see that the 2 forms, IV and subQ, match each other very well and closely. The trouble here is that with the FcRn, when you give them in cyclical treatment like this, they improve most at about a week after the last infusion, but then they start to drift back to baseline, so they get worse, and that's turned out to be an issue with some patients. What argenx did was to study fixed cycles versus every 2 weeks dosing. And this data was presented 2 weeks ago at the AAN, and this is a screenshot, so the quality is kind of crappy. But anyway, so the patient got 3 cycles, or 1 cycle at the beginning and then every 2 weeks after. And you can see that the response was very similar across the board. And here is also the Christmas tree where the percent of patients who improve over time, as you know, more improvement going up this way. You can see that they're very similar as well. Rozanolizumab is an FcRn inhibitor, and you can see the same pattern. So this is 6 weekly infusion, and you can see the treatment result in drop in ADL and IgG, and then the response starts to wear off. But when you give the patient different cycles, you can see that the duration, the effectiveness is pretty durable across cycles. There were 21 patients with MuSK antibodies in this study, and you can see that placebo patient got worse. They had a 2-point increase versus patient who was on 7 milligram had a 7-point improvement, and the 10 milligram group had 4-point improvement. Because of these results, the FDA gave rozanolizumab the indication for MuSK antibody associated with MG. Here are the most common side effects. Headaches is usually fairly common across the board, and some other ones as well, similar to C5 inhibitors. Okay, so we're going to go upstream now and talk about B-cell depletion. There's a lot of agents you can see here. Unfortunately, a lot of them fail. The only one that we have ongoing is inebilizumab. That phase 3 is ongoing, and there should be a result coming out in the next year or so. The other thing that gives us a lot of promise is CAR T-cell therapy. So as I mentioned before, after activation, the B-cell transforms to plasma cells, and that process is listed here. And during development, these B-cells would pick up protein markers on the surface called CD, and that, like for example, CD19 here is expressed throughout. CD20 is expressed in some phases, and then BCMA expression is for the later phase of the development. Rituximab has been used a lot. It targets CD20. And so this study looked at steroid-sparing effect. So the idea here is if I give the patient Rituxan, I should be able to get the patient off prednisone. Unfortunately, that study failed. There's another study in Sweden that looked at early onset patients. So these are patients within a year of onset, and they have not been treated with immunosuppressant. They can be treated with steroid, but at high dose. And you can see that with one single dose of 500 milligram of rituximab, the patients so here's on the left is placebo, on the right is the drug treated group, and you can see that minimal manifestation was achieved between 60 to 70% of the patients, and the patient who was treated with drug was less likely to relapse. But that's a very specific group of patients. And I'll talk about CAR T-cell therapy next. So this technique has been used to treat B-cell lymphoma. And so what they do is they draw blood from the patient, isolate with T cells, and then make them expand in the lab, and then label them with a marker. And you can think of this as weaponizing the T cells, and then take that T cells and infuse back into the system. And whenever the T cells see anything that matched that marker, it will kill it. So you can see it here. And so basically, there's 2 ways of doing this. One way, the old way, is basically use DNA insertion into the T cell DNA, and then that DNA would then get transcribed and put this marker on the surface. Or you can use RNA, where you just induce this marker making without changing the DNA. So the first study I'm going to talk about is the RNA CAR T cells. And so basically it labels the T cells to recognize the BCMA markers, and that markers is on plasmacytes. So that's the plasma cell that will produce antibodies. And okay, so here's the preliminary results. In the patient, we see improvement across the board and across different measures and so on. So the results look pretty good. This is a phase 1/2 study, so we're still waiting. We just completed the phase 2, and we're waiting to see what that show. The side effects are pretty minimal. So the advantage of RNA-based technology is that you don't have the complications that you often see with the DNA-based CAR T. Here's another study that looked at DNA-based CAR T. This is a single case report from Germany, and you can see that this is a 33-year-old woman who was diagnosed 12 years ago, and she had failed multiple treatments, including thymectomy, rituximab, bortezomib, which is a antibodies against B cells, mycophenolate, IVIG, steroids, and she was not able to walk. And so they treated her with CAR T cells, and you can see that she was able to pull her arms up after treatment. She was not able to walk before, but now she's able to walk fairly long distance, and all the other markers also improved. So, consider how severe she is and how responsive she is to treatment. That's the really encouraging findings. And then the last one is T cells, other than, so basically satralizumab was presented at the AAN 2 weeks ago, and basically it reduced antibodies and reduced inflammation. And you can see that the placebo group and the treated group both improved, but there was not much of a separation. So the the primary endpoint was not met. So unfortunately, the drug probably won't be developed. My feeling about this is that if you look at the response curve, it's a straight line, which means that they probably cut off the study too early, because you don't know what happened 12 months or 24 months out there, and for B-cell therapy, you probably need more than 6 months. But unfortunately, that's going to be the end of that drug. So let's talk about the future. So, when I went to training residency in the last century, 1990, it's still last century. So, but, the idea back then was to keep the patient alive. In the last couple of decades, we improved to make the patient better. We're at the point now where we can actually make the patient normal, or at least back to where they were before they had MG. But we're going to be a little bit more demanding. We certainly can get the patient there if you give them really high dose steroids, but then they have all sorts of side effects. So you don't want that. So you want minimum symptom expression, but you also want minimal side effects. And the last thing you want is probably just one drug. You don't want to take 5 of them every day. So what we have here is that newer drugs have very quick onset of action, so the patient can be relieved of their symptom very quickly. They have more tolerable side effects in the long term than, let's say, steroids. And the third point is bring up the most favorite word for me in the English language, and that word is "or." It infers choices, and that's important because now you can customize the treatment to the patients. And as you know, no patients, 2 patients are the same. So being with the individualized treatment is something that we always search for. And it's very convenient in terms of treatment. The biggest disadvantage is cost. And there's a lot of companies, insurers out there that require you to step through. You have to try this, and other things before you get the drug. Like I said before, the employment, we have an employment-based health insurance system. If you're sick enough, you're not going to work. If you don't work, you don't have insurance. You can't afford these medications. And that's a really catch 22. If you have seronegative MG, there's no medications out there that's been approved in the US. In other countries, seronegative patients get approval for some of the medication that we have right now. So all these choices, which one are you going to choose? And I can't tell you which one will be the best because there's no head-to-head comparison. And each study have a different design. They have different populations. And so compare them across the board without a head-to-head trial is not something we would do. So the other thing that we need to do is how long is long enough? So as I showed you earlier, at least with the complement inhibitor, the longer you stay on it, the better improvement you see. And the FcRn inhibitor as well, the more cycles you try, your chance of improvement increase as well. So it's something that we need to work out. If you, let's say you try drug A in the same class and it doesn't work, would you be able to try drug B or C? That may be related to how the drug is, whether it's a peptide or monoclonal, is it a fragment of antibodies or the whole thing? So it's something that we need to work through in the future. Remember that C5 inhibitors work only with binding antibodies. So what happens when you have binding, blocking, and modulating antibodies? What are the benefit? What's the contribution of the two other antibodies on your disease? And we actually don't have any data on that I know of. Treatment burden. So, you know, all the drug companies out there want to make the treatment as simple and convenient as possible. Sometimes the FDA get in the way. For example, the FcRn is now, have to be administered by healthcare providers to make it less convenient. And for complement inhibitors, you need to be vaccinated against meningococcal meningitis. And the FDA just gave new indications before you can start the first set of vaccination and then start the drug treatment 2 weeks later. Now you have to complete the cycle, which may take up to 2 months. They do defer to the ACIP guidelines, which is a little bit outdated. So more to come in that space, I'm pretty sure. They all essentially have the same effects, side effects. So that's not too much of a, hang back for me. So in conclusion, this is an exciting time to be in the MG space with many efficacious, rapidly acting targeted drug available in development. FcRn and complement inhibitors are efficacious and in controlling GMG symptoms in many patients. And in my experience, many of these patients do reach MSE on single therapy. Upstream agents and treatment may be available in the future. And achieving excellent disease control is possible. And I will finish with this slide. We used to not treat the patient, but amuse them. Back when I was in training, diagnose and adios is our model. But, now I can say, hey, I can do something. And notice the emoji. I guess no modern communication is complete without that. So thank you. So that was pretty quick. Thank you. Any questions? Yes. Catherine, can you start the wave back there? Yes. So, yeah. Yeah.
You pointed out some of the medications, you're not sure how each patient's going to respond. Like I can be, I can have binding, blocking and modulating antibodies and someone else can have the same, maybe won't get the same response. And I understand that that may still continue to be a problem. But my question is, where are we in terms of the challenge that I see is that not all patients are getting all of the same testing. So in other words, I will see where a patient tests positive for binding, but then the physician does not go on to test for modulating or for blocking. They simply just start treatment, right? And so the challenge that I see is that until all of us get all of the same testing, for instance, I know that I'm AChR seropositive on binding, blocking, and modulating. However, to this day, I have not been tested on LRP4. I'm pretty sure I don't have that, but either way, like I said, that's maybe less of a problem for me, but for other people that don't know, all they know is that they have binding, they're positive, they're getting tested. Like we're not going to see the commonalities that we all have until we all start to get the same testing. And so I was wondering, from your perspective, where are we on that, on getting more uniform testing for everyone? I think we should all get tested for all of the 6 antibodies that are, that right now that there's treatments for. So for all the AChRs, LRP4, for the striated muscle antibody, for MuSK, like just do it across the board, everybody, so that we can start to see those commonalities rather than just be snowflakes forever. I think it might help. So I just want to know from your perspective where we are on that.
Yeah, I think that's a really good point. And to be honest, some of the study did not look for all 3 antibodies. I think, my practice is to basically test all 3 antibodies. Having said that, binding is the most common. And then to have just blocking or modulating alone is extremely rare. You're talking about 1 or 2%, but it can happen. But the more important point is if you have 3 antibodies and you block the complement cascade, what are the other 2 doing? And we have a patient in this room who have just modulating and he did well with, treatment to remove that. So they do contribute, but we just don't know what proportion. So definitely. The number of patients out there with MuSK and AChR antibodies are really, really low, really rare. Been reported, but it's really rare. LRP4 is actually a interesting antibodies, mainly because you can see that in other diseases. In Greek population, for example, you see the antibodies in patient with ALS, and we've come across that a few times here as well. So unless you have, no other antibodies, I would test for it. The other problem is that there's not a lot of facility testing LRP4 right now, so that's another challenge. Sure. Thank you.
Next question, considering where the different drugs are in testing with the FDA right now, as well as the few that have rolled over past phase 3, do you see a future where you could streamline this or compress the timelines on treatment with a pharmacogenetic test that would narrow down very quickly what the treatment should be?
We don't have a marker. People have look at different markers. There's some study that show IL-6 level go up when you're about to have an exacerbation, but we don't really have a marker to say which drug going to be the best. And I think that's possible in the future, but not anytime soon that I can see.
Good afternoon, doctor. Thank you. A question with regard to seronegative. Is a patient, if I guess tested seronegative, would there be anticipation of further testing maybe down the line or a few years later? Or is a patient once seronegative, always seronegative? Thank you.
So if I see a seronegative patients, simple things I would look for. So things like plasma exchange recently before testing will make it negative. And certain medication like mycophenolate may turn it negative. IVIG may mask the result. So if the patient haven't had those done recently, let's say in the last 3 to 6 months, then the next step I would do is, does this patient really have seronegative MG? Because things like mitochondrial myopathies or oculopharyngeal muscular dystrophy will mimic MG. And in those patients, I would consider genetic testing to make sure. I actually pick up somebody who act like an MG patient, but seronegative, and he turned out to have a mutation in the MuSK protein. And so treatment like that is, testing like that's important because I know that that patient will not respond to any of the drug I'm using and save him a lot of money and potential side effects. There are patients out there who, there are patients out there who are seronegative and act just like a MG patient. And for those patients, we do other things like single fiber EMG and repetitive stimulation. And in some study, they also require the patient to be responsive to mestinon.
I see Jerica Farias at USF and have for many years. My question is about a lot of the new medications are injectables or IV. Do you see a future where those could be offered in pill form, or is that not possible?
There are studies out there that look at pill forms, but we don't have the results yet, and I'm not supposed to say anything about them. Sorry.
Hello. Yeah, I had a question. You said that it's difficult to choose between, I think, the component of the FcRn inhibitors as therapies, but is there any research into combining the two, or are they contraindicated?
So the FcRn clear out IgG. So if you use that with if you use that with eculizumab or ravulizumab, you will clear out the drug. And in fact, if you do plasma exchange or use that FcRn inhibitors, you actually need to give them supplement dosing. The other C5 inhibitor, zilucoplan, is a polypeptide, and that is not cleared by FcRn, so that potentially can be used together. The problem is that these medications are really expensive. It's going to be really difficult to get the insurers to approve both of them.
Yes, doctor. I've heard a rumor that there may be a shortage coming of mestinon. Do you know if that's true?
Not that I know of. I haven't heard that.
I'm a fellow mestinon addict, so that was disturbing. I'm interested in, have we looked at the correlations between physical measures and survey responses to understand how, like, a physical measure of antibody levels in the blood correlates with the survey response in the activities of daily living and the levels reported there? And is there anything interesting to learn there, or is our N? I work in a world where my N's are in the hundreds of millions, so
Right. So
these are very hard for me to interpret.
So if you look at a cohort level, if you look at two groups, you can't tell the difference. So if you look at a group difference, there's no correlation. But if you look at individual, there's probably a correlation, because we know that when we give you patients FcRn or plasma exchange, you reduce the level and the patient do improve. So at a patient level, I think there's some correlation. but as a cohort level, if you have a level of 2 and I have a level of 10, doesn't mean that I'm 5 times more effective than you are. But if I go from 10 to 2, I probably improve. I don't know if that answered your question. Yeah. Yeah, no, it's a survey, give you a sort of an idea. It doesn't give you a lot of good data because with MG, if you have a good day, your response is going to be different than, a bad day. So, but, if you do large enough number, that may be helpful. And that database set out there, that's fairly large. And we've been looking at them too. So one of the database that we look at, the VA, they have excellent records over years. The problem with that is 96% of them are males. So it doesn't apply across the board. Yeah. Right. Yeah, there's some study are looking at that. The trouble is some part of Florida is still pretty rural where there's no Wi-Fi access, and that make it difficult.
I have a question about the person that is seronegative. I'm over here on the left.
Oh, sorry.
I imagine there's a lot of people in the room that are seronegative. And my question is, how do you navigate testing in between patients who need IVIG or Plex? How do you manage that so that you can get an adequate test and maybe see if there is an antibody that presents? I know it's a tough one, but I bet it's an everyday question for a lot of people.
Yeah, that's a tough one. I don't know how to do that. I probably would look for other things like single fiber EMG to see if there's any blocking or, that sort of thing. Or find a time when the patient actually, is in between treatment. And sometimes we do that. Those patients I also would lean toward genetic testing, make sure that the patient doesn't have any other muscular diseases that can mimic.
Question about technology as it applies to collecting data and data in real time about how well we're actually reacting to a therapy. We fill out a form with a paper and pencil, essentially. How do we move to a future where we're actually collecting data digitally and then leveraging the tools that are out there to analyze that data?
Yeah, actually, there's people who are doing that sort of thing, not in this space in particular, but in other space, in neuromuscular diseases where, they would track steps and level activities and that sort of thing. It's actually pretty challenging to do so far. I think the technology is not quite there yet, but I imagine one day it will be. But I think, in 5 years, we're going to pretty much solve all the bugs. The other problem is that, people don't like to, wear a device on them all the time. So compliance for us has been an issue as well.
Dr. Vu, we have a question from online. If you want to talk a little bit about treatments in the pipeline for MuSK MG, if you can talk about that a little bit.
Some companies are, for example, coming back and try to pick up those patients and see if that drug would work on it. So there's a couple in development right now. Some of the CAR T-cell companies are looking at MuSK as well. But we're still pretty far away from, having anything concrete available. Other than that, we do have one drug on the market for that, and plasma changes and Rituxan are the other possibilities.
maybe one or two more questions, I think.
Just real quick, can you talk a little bit about the muscle groups that are affected by MG? I've always been told that it's, your legs, your arms, my diaphragm was affected. What about other muscle groups like bowel and bladder, things like that?
Yeah, it's usually voluntary muscle, the muscle you can control. So it usually doesn't affect involuntary muscle like those that control bowel movements and so on. However, a lot of the drugs that we use do affect that. So Mestinon, for example, will give you abdominal cramps and hypermotilities. But other than that, in terms of voluntary muscle, any voluntary muscle you have can be affected. Usually the muscle that bear weights and do a lot of activities, the one that affect the most. The eyes are particularly, often affected because you're blinking your eyes and you move your eyes constantly. So, and then of course, like you mentioned, respiratory swallowing and that sort of muscles. Yeah. Oh, I'm sorry to say. Yeah, I don't know about that. I don't have an answer. The question was about pelvic floor muscles, and I haven't come across anything in regards.
Hi, one of the slides had mentioned that one of the bad things that it's occurring is that the insurance companies aren't covering a lot of this. So all the testing and all the trials and everything it's all great and all the research, but if it's not made available to the patients, it's all kind of moot. So I'm wondering if there's anything being done to work with the insurance companies to make sure that these trials and all this medication and everything is being made available for these patients.
I would defer to the MGFA for that one. From a personal perspective, I do try to get talking to the insurers about all the other options. And sometimes, you have to talk to them and say, look at all the costs that you don't see. So if this patient keep on going to relapse and crisis, and he or she get admitted to the hospital 3 or 4 times a year, that will cover way more than any drugs out there on the market. So sometimes just bring that up and, to the insurers will help. I think the problem with all this is that we don't count hidden costs. So if you're on steroid for a long time, you have hypertension, obesity, thin skin, fractures, whatever, but we don't capture any of that in our, measures of how much it costs to treat a patient. We just worry about, $1 pill versus how much over on the other side, and make a decision based on that. And I don't think that's a fair assessment.
I think we're good. Thank you very much,
Thank you.
Dr. Vu.
Thank you, Dr. Vu. Thank you very much. And thank you to all of you for asking your very thoughtful questions. And there will be a lot of opportunity to interact with the speakers over the next few days. So please feel free and keep the questions coming. So now it's time for dinner. We're a little bit behind schedule. I'm sure you guys are hungry. It's already been a long travel day for a lot of you. So dinner will be served right out in the foyer past registration. You'll see tables all set up out there. And then the award ceremony is scheduled for 7 o'clock. We want to give you ample time to eat and relax. So we'll start wrangling folks around like 7 o'clock or a few minutes after that. We're not going to rush you or anything. With that said, we don't want to make it a very late evening. So we'll probably start the award ceremony soon after 7 o'clock and try to wrap up by 8 o'clock. Okay, so enjoy dinner. Thank you.